Good evening, everybody. I am Dr. Tanuj Lavanya Rai, and today we have a very famous gynecologist with us, Dr. Hemant Kanodia, who has specialized in the endometriosis and the pelvic surgeries. And today he'll be throwing some light on this disease, which is very less known about and very less talked about. And we see a lot of women in our OPD who come with chronic pelvic pain and infertility. And most of the times we just tell them some, like you take OC pills or you take painkillers and everything is going to be all right. Or if any unmarried female is coming, then most of the times she's advised that, once you get married and once you have children, everything is going to be all right. So it is a very less known disease. And we have with us Dr. Hemant Kanodia, who will be answering the most common questions that the patients have. So shall we start, sir?
Okay, thank you, Tanuj, for having me over on your platform. And I know you're into social media and doing some really good work creating awareness on women's health. And I hope you just keep up the tempo and wishing you all the best. So thank you so much again for inviting me, and let's roll on.
Thank you so much, sir. So we'll start with a brief thing, sir. So I just want you to tell in very simple terms what exactly is endometriosis and what are the most common symptoms that we see with the disease.
Manner, which react in a particular cyclical manner every month, and the endometrium grows. Okay, and if the pregnancy doesn't take place in accordance to the ovulation and the egg coming in the uterine cavity, but probably not getting fertilized by the sperm. Okay, so what happens is that the grown off endometrium just sheds off at a particular time in the month, and that is what we call as the period. Okay, which mainly looks like the red colored bleeding. Okay, but it contains pieces of endometrium also. So endometrium is nothing but lining of the uterus. Now this lining is supposed to remain within the uterus under normal circumstances. What happens in endometriosis is due to whatever reasons, most of the reasons are not known. Even after 100 years of this word endometriosis being coined by Samson, okay, we still don't know the exact origin of endometriosis. So what happens is the lining of this endometrium is supposed to be in the uterine cavity only, but this is abnormally present out in the abdomen, a responsive tissue, the endometriotic tissue. So it responds in the same manner as the uterine lining responds, and there is cyclical bleeding within that tissue also. Now this bleeding, small bleeding causes, or micro bleeding, what we causes some kind of an inflammatory reaction within the body. There's more to endometriosis, but this is in a simple manner that I have tried to explain. And when this micro bleeding takes place, there is inflammation, fibrosis, and things get stuck around in the pelvis with the important organs. And that, in short, or as a summary for a layman, is what endometriosis is.
So what is the incidence of endometriosis in our country? Because I think in India, there are not much studies which are done on endometriosis, and it is a very less talked about condition. So in general, absolutely, in our population, what is the exact incidence? Like, can we know about it?
So let me tell you some global data before we come to the Indian data, because that is quite 1 in 10 women or females in the reproductive age group are known to have endometriosis. So that is quite common, and the worldwide estimate overall at the moment is around 190 to 200 million females. Out of which in India the data is not very clear, but according to the estimates, it is around 20 to 25 million females. So what I'm trying to say is endometriosis is almost as common as diabetes, but the kind of research, kind of awareness that is created on diabetes, we don't have even a fraction of that for endometriosis. Even the funding in terms of research for cure of endometriosis, diabetes is so massively spoken about, in various segments across various sectors of the society. There's so, believe me, is almost similar like diabetes, because it cannot be totally cured. It's a condition which will remain with the female probably lifelong. It can be regulated. It might tone down a bit or it might become more severe, but it can't totally go out of the body once you have it. So just imagine it's like diabetes, but doesn't even get fraction of the attention it deserves as that is given for diabetes mellitus.
Yes, sir. So, like, who is more prone to develop endometriosis? Do we have a genre which is more prone to develop this condition?
See, it's something associated with the menstrual be at a little higher risk. Okay, patients who don't get pregnant, early in life and push off pregnancy, they are definitely going to have uninterrupted menstrual cycles because pregnancy causes a temporary sort of menopause state or a pseudopause kind of a state. For those 9 months, you don't get your menses; it's suppressed because of the pregnancy. So somebody who has delayed pregnancy, so that person is exposed to more number of menstrual cycles uninterrupted in that way. Okay, people with the high body mass index, because this is an estrogen dependent disease, so a high body mass index might, there is a genetic, so it is a known years, genetic, and the very theory is also a postulation takes place. The blood flows from the mouth of the uterus, that is the cervix, into the vagina and into the outside, right? That is what we call as menses. Similarly, there are two tubes which are connected, or the fallopian tubes, okay, which carry the ova cavity, that is known as retrograde endometrial debunked. All females have some. So the latest theory, there are many other theories of metaplasia, conversion of the peritoneal cells. The latest theory, what is believed that this is abnormal migration and differentiation of the cells in the embryonal stage only, which happens and which remain quiescent till the hypothalamic pituitary axis gets activated and the estrogen progesterone start triggering the process of endometriosis or the cells of endometriosis.
Yes, sir. Sir, understood. So mostly it is the genetic implication. Like some people are designated to develop endometriosis over other people. Like that's what is the most accepted theory, right?
Yes.
Okay.
There is something known as epigenetics also. Okay, there's an element of epigenetics. There are certain diseases which are related to epigenetics. Now, what is epigenetics? There's not a mutation in the gene, but the expression of the gene is affected due to various factors. So there's an element of lifestyle element also in this, which can cause endometriosis, similar to diabetes, how lifestyle modifications can cause or trigger the event of endometriosis.
Yes, sir. So what are the most common symptoms and signs the patient can have who's suffering from endometriosis?
Yeah, so actually, most commonly, these patients present with painful menses. Now, and that is where the problem lies in diagnosis, because if you see, almost 100% of the females are going to have some amount of pain during menstruation, which is known as dysmenorrhea.
Yes.
Okay, so the problem lies in how to pick up those who are having endometriosis, as this is one of the main symptoms. So we have a way of quantification of the pain. So we have various visual analog scores on which the pain can be quantified and scored. So these scores are mainly out of 10. So any pain during menses, which is more than 7, 8 out of 10, 7 to 8 out of 10, should at least raise a red flag or a concern amongst the physician that this could be endometriosis and needs to be further evaluated and investigated and not be brushed under the carpet or taken lightly. There's a very good term known as medical gaslighting, where the patient symptoms are dismissed off, they are taken, they're not taken of an average of 7 to 10 years. So you imagine, and it's a progressive disease. So you imagine how much of a golden time that we are losing, or a golden period of time we are losing, where the disease progresses and it's not diagnosed or misdiagnosed for various reasons, and the lady is, and the painful menses. It could be also associated with some form of change in bleeding, or the bleeding pattern or the menstrual pattern could be associated with heavy bleeding. If the surrounding organs are suffered, like the intestine, they suffer or are affected, then you can have painful passage of stools. You can have painful passage of urine, painful intercourse when the inner layer of the peritoneum is involved. The patient might complain of painful sexual relations or intercourse. Okay, or there could be chronic pain in abdomen, not only really common, but certain effect on sort of prevents, absolutely evaluated for endometriosis. Like you have a schoolgirl or a college going girl, and they're having a lot of absenteeism because of pain. That should raise a red flag, that something is wrong and might not be endometriosis, but has to be really investigated in detail for endometriosis, because if picked up early, it can be brought under control, and the devastating consequences that this disease causes because of its progressive nature in most of the females.
So, what is the most common modality with which we can diagnose this disease if we know the symptoms?
Yeah. So as I told you, there's no screening method where, we can pick up in our outpatient or in our office, clinic office, and we can, say that we can screen these females like mammography for breast cancer or the pap smear for cervical cancer, which is a screening modality to filter out the high risk population. Here you can only rely on the symptoms, which probably act as a filter to filter out certain females who might be having the severe symptoms. The modality of investigation primarily remains imaging. So imaging could be of the two types, that is the ultrasound and the magnetic resonance imaging. Is observer dependent on how they interpret the images, but a sonographer who is trained in picking up these endometriosis signs on ultrasound can pick up almost to the tune of 95 to 98% of the nodules or the endometriosis disease. MRI is much more standard because you have standard images and you can interpret them much more easily. And ultrasound technology and with the interpretation among the sonographers quite well. Am I
So,
audible
sir,
now?
yes, you audible. The network is going in between, sir. So, one part was
Okay.
little lost. So, it's because my net is coming full only, sir. Like it is coming fine. Can you
Mine
please?
is also, it's showing at least all the bars, but you never know with the rains in Mumbai. I don't know now, but I think now we are okay. And did you
Yes.
lose a lot of what I said on imaging or?
Imaging, sir, I got the MRI and the ultrasound part, but like
Yeah,
little bit I lost in between. So I'll just manage with that. Not a problem.
no problem. No
Yes,
problem.
sir.
You can go ahead.
Yes, sir. Sir, so then next question that I think most of the people will have is the people who
Yeah.
suffer from endometriosis, can it affect their fertility and chances to have a child?
Yeah. See, endometriosis is a disease that affects the reproductive organs, primarily the uterus, the for the female, cause 50 to 60% of inconceived. Tanuj, I think you again lost me.
Yes, sir. I lost you,
Am I
sir.
audible?
Yeah. Now you are audible. Yes.
Now,
In between, it
now
is
we are
going,
good.
sir. Now we are fine.
Yeah, okay. Now you're audible. So I'll just answer your query again. So the females suffering with endometriosis might have an incidence of infertility as high as 50 to 60%. And the females presenting with infertility, there is almost 30 to 40% chance that the cause might be due to endometriosis. So what endometriosis does is, it primarily, as I told you, it's a wear and tear disease. There's a repeated wear and tear taking place with incomplete repair. Normally, when you have an injury, there's wear and tear and there's a repair that is taking place. In endometriosis, there is cyclical wear and tear with incomplete repair, which leads to fibrosis. Fibrosis is nothing but thickening of the normal tissues. And there are adhesions that is sticking of the surrounding organs with each other. So what happens is there is complete distortion of the normal pelvic anatomy. The relationship between the organs like the uterus, the intestines, and the bladder, which is normal in a normal pelvic anatomy, is distorted completely. So this distortion is one of the cause of infertility. The other cause is endometriosis. It's an inflammatory condition. So there's a release of a lot of inflammatory substances like cytokines, interleukins, and many other prostaglandins, etc. during the inflammatory process. So these inflammatory substances, they alter the complete milieu or balance of the pelvis. So they completely cause chaos and havoc within the pelvis, and that is another reason why patients find or have a problem in getting pregnant.
Yes, sir. Sir, another most common question that I came across was can endometriosis cause cancer of the pelvic organs?
Yeah, that is a commonly asked question, as you said, amongst and the concern amongst patients.
Yes,
But there is, let me tell you, still insufficient data. But according to the current data, and in my experience also practicing for 23 years, I've never come across an cancer occurring in endometriosis. The chance is less than 1%. Okay, only mainly with certain specific type of ovarian endometriomas where the ovary is affected, there could be an endometrioid kind of ovarian cancer, a small possibility, but it's not very common. So I think this apprehension and anxiety from the patient should go away because it's not very common.
Okay, sir. So what are the treatment options available for the patients, sir, depending on the disease?
Yeah. So before we come to the treatment options, let me tell you about the types of endometriosis. So there is something which affects the ovary, which is known as the ovarian endometrioma. I mean, ovarian endometrioma actually starts on the surface of the ovary. There's a small patch which invaginates into the ovarian cortex or the ovarian substance and forms a cyst. Now, cyst is a lining which contains fluid. Now, in endometriosis, there's microbleeding taking place. So there's microbleeding takes place and there's altered blood inside, which looks like a chocolate fluid. And that's why this is called as a chocolate cyst. Amongst the common people also know this term as chocolate cyst. It is nothing but an ovarian endometrioma or endometriosis that affects the ovary. The other problem or the other organs which mainly get affected is the peritoneum. Peritoneum is nothing but the inner lining of the abdominal cavity. It is a covering over the various organs of the pelvis. So you can have superficial endometriosis. When the invasion in this layer is less than 7 millimeters, it is called as superficial endometriosis. And then last, and which is the most dangerous, is the deep infiltrating endometriosis. When the invasion of the endometriosis goes more than 7 millimeters, it is called as deep infiltrating endometriosis. And these endometriotic lesions can be present on the intestine. Now, the lower part of the intestine is mainly the rectum, which actually stores the stool for the last path when it's coming out, the rectum and the sigmoid. Okay, this are the main in part of the intestine which is affected. And then anteriorly, there is the urinary bladder, which can get affected. Then there are the ureters. These are the tubes which carry urine from the kidney to the urinary bladder. Okay, they can be involved because they course along the same track where the ovaries and all these important structures are lying. So they can get, pulled towards the lesion or, get kinked, or sometimes there is a nodule covering the ureter, which causes compressive symptoms. And the path of urine is obstructed, which leads to hydroureter and subsequent hydronephrosis in the kidney. Elements of the uterus, like the uterosacral and all, which support the uterus, can get affected. So this is coming to the types of endometriosis. Why I told you about the types of endometriosis, because endometriosis is of different grades. So it could be from grade 1 to grade 4 or from mild, moderate to severe. Now, depending on how much these organs are involved, to what extent they are stuck to each other, it is graded and given a score of severity. So there is a classification known as Enzian classification also, which is the latest classification, which helps us in better grading and clinical or correlation during surgery. Okay?
Yes,
So this classification can be picked up on imaging and you can plan the surgery properly.
Yes, sir.
As far as treatment option goes, it depends upon the type of endometriosis. It depends upon the age of the patient. It depends upon the goal of the patient and the symptoms of the patient. I mentioned symptoms last, but let me tell you, endometriosis management should be totally symptom-centric. Now, why I say that is because this is a totally enigmatic disease. It's a big puzzle, because sometimes the clinical findings and the symptoms don't match with each other. So you might have a grade 4 severe endometriosis patient with minimal symptoms. Okay, so sometimes we just find it on a routine laparoscopy we are doing for an infertility evaluation to find out cause, and we see grade 4 endometriosis. Okay, and the patient doesn't have the kind of symptoms with the matching with the severity of the findings. And you might have mild to moderate endometriosis producing a lot of symptoms. Okay, now coming to the treatment, the modalities, we obviously give a trial of medical management before we go for any surgical management. So that's normally the first line, but there are a few exceptions. If there is a very big endometrioma, say more than 5-6 centimeters, then it needs to be tackled surgically, because the medical management might not act, so fast or efficiently on that. So the medical management is the first line. Medical management mainly involves suppression of the hormonal axis, because these are estrogen dependent tumors and they react to the hormones that are secreted in response to the hypothalamic pituitary axis. So what they do is they create a case, sort of a pseudo menopause, where they suppress all these hormones and the lesions become quiescent over a period of time, and they do get suppressed. So there are various hormones in the form of say tablets, injectables. Then there are intrauterine devices which can be kept within the uterine cavity, which secrete automatically secrete hormone progesterone, which causes suppression of the endometriotic nodules. But the problem with medical treatment is once you stop this, okay, it gives you temporary relief. But once you stop the medical management, there are high chances that the symptoms are going to come back. So it is okay for temporary relief or to buy some time till you're waiting for the further management. But the ultimate goal or the ultimate treatment for severe endometriosis or deep infiltrating endometriosis is surgical excision of the endometriotic nodules. So whatever macroscopic disease you're seeing while we are operating with an endoscope, we need to remove that. So what this does, it actually causes optimal debulking of the disease. See, you can't remove everything because I told you endometriosis, there might be microscopic implants. So you can't completely get rid of the disease. But what we have seen is that we optimally debulk all these visible lesions. It causes a tremendous improvement in the quality of life of the patient in terms of better quality of life, better relief from dyspareunia, that is painful intercourse. And if there is a bowel endometriosis, that portion has to be taken out so that the compressive, because these bowel nodules can cause obstruction to the passage of stool.
Yes, sir.
So if you excise those nodules, there's definitely relief. The prime aim is to make them pregnant. Okay. And if they're infertile and they don't have too many symptoms like pain, then definitely they can go in for something known as ART, that is assisted reproductive techniques, to probably get them pregnant faster. Because I told you these patients are suffering from a problem of infertility or delayed conception or inability to conceive because of the various things I told you how endometriosis affects fertility. So if that is the goal, then you can think of things like ART, in which you have IVF and test tube baby, ICSI, all these things.
Yes,
so that in a nutshell is how the treatment options are.
Sir, so like once the patient has undergone the surgery, then also the chance of recurrence is there after the surgery?
Yeah, so I told you that it could be a microscopic disease which might sort of grow later. Okay, but what is seen is that if this surgery is done in an optimum manner, okay, by the right surgeon. These surgeons are known as endometriosis excision specialists. Now, who are endometriosis excision specialists? They are not the routine OBGYNs. Okay, they are people who are focused on endometriosis with a special interest in this area, have devoted their time, honed their surgical skills to manage these conditions, and have those expertise and necessary skills to carry out the surgery. So as I told you, that this disease affects various surrounding organs in the pelvis, the critical organs like the bladder, urinary bladder, the rectum, the sigmoid large intestine, the ureters. These are all critical organs. Okay, so a gynecologist per se, a routine gynecologist is per se just trained to focus on the uterus, right? Mainly, that's what we are taught almost world over in our training program, in our initial residency days. So we are not, having a holistic approach or a complete 360-degree approach to the pelvic cavity. Now, endometriosis excision surgeons are nothing but, the right term is pelvic endoscopic surgeons. So they are equipped or trained to manage everything within the pelvis. So the ureters and the bowel and the urinary bladder, primarily as gynecologists, yeah, they do take some kind of support or inputs from, say, urologist or colorectal surgeon as a multidisciplinary team. But it's primarily the gynecologist who is in charge of that situation, because nobody understands endometriosis better than a gynecologist. The colorectal, the urologist are never trained to manage this disease. You understand? And it is totally different from cancer. Okay. So what I'm trying to tell you is if the surgery is done by the right person or the right endometriosis excision surgeon, and there are a good amount of these kind of surgeons all over India, although the ratio is quite less, but they are there, they're available all over India. So if the surgery is done by the right person at the right time in the right manner, then the chances of recurrence are very less. So recently, just yesterday, we have had a paper from one of the world authorities, Dr. Horace Roman from France, who has done extensive work on endometriosis. He runs the Center of Excellence of Endometriosis in Bordeaux, France. So he has come out with a paper where he evaluated almost more than 1,000 patients over a long period of time, I think around 10 to 15 years. And according to him, a well-done surgery also has a recurrence rate of around 28 to 30% after 10 years. Okay. But
Yes, sir.
the intensity of recurrence might not be as much as how it was during the primary disease. So the pain might not be so much. The pain score might not be so much. And many of these patients later on, they present for hysterectomy because the chances of recurrence are least when you remove everything, within
Yes,
the uterus.
Mm.
That does not mean that doing a hysterectomy and removing the ovary is a cure for endometriosis. That is a part of it. The complete treatment is removal of the uterus, probably the ovaries if they are affected, and radical excision of all the endometriotic lesions within the pelvis and sometimes outside the pelvis also. So in few situations, not very common, but you do have extra pelvic endometriosis where the small intestine is affected, the diaphragm is affected, the appendix is also affected with endometriosis, even the lungs might be affected.
Yes, sir.
So again, this also not very common, but does require multidisciplinary approach and can be tackled. But I'm primarily talking about the pelvic endometriosis, which is much more common. So yes, the chances of recurrence are there, but a well-done job, the patient has a good quality of life for an extended period of time. And the first surgery should always, as far as possible, be the best surgery. And that's why it needs to be done by a specialist who is an expert in managing endometriosis.
Yes, sir. Sir, there's one more question that I want to ask. As we are seeing rising incidence of cesarean sections, so, sir, there's something which we call as scar endometriosis also. So, while doing a cesarean section, what can we do as a obstetrician to prevent, scar endometriosis happening? Like from our side, what can we do?
I can tell you logically speaking, because I have not done a cesarean for the last more than 18 years. I'm not doing obstetrics, but what I feel is that, probably taking care that there's less spillage of, whatever the endometrial tissue or the liquor and all what is coming out, the placenta when you are removing, you remove it carefully, and so that the tissues don't sort of get implanted or spread to the surrounding superficial layers like the skin and the subcute fat sheath. I think that is good enough. Giving a good wash might help. These are a few things that might help, but then let me tell you, it might just not be dependent on these factors. It might be the inherent trigger. A lot of people might be getting implanted by those cells, but only few of them get scar endometriosis, not all of them.
Yes, sir.
So it's
Yes.
again the tendency. It's
Mm.
again the tendency which could have, probably a genetic implication or something. So it's not totally under our control. But as far as I know, logically speaking, you can just take care that the tissues, don't spill over onto the layers of the abdomen as far as possible, because it's not totally avoidable kind of a thing, but it can be decreased.
Yes, sir. Sir, so I think it is very extensive session on endometriosis, and I'm sure a lot
Yeah.
of people will get, full knowledge regarding this condition. And I don't think they have to watch anything else after watching this
Thank you
thing
so
with
much.
you, because you've explained it so well. And I think everybody will understand what exactly endometriosis is, what are their options, and they will know what person they should go to. Because in our country, we don't have many pelvic endometriosis, like surgeons who are actually focused on endometriotic surgeries.
Yeah, I'll tell you why, because it's not part of the residency training program. So
Yes,
we
sir.
have to specially on our own, hone our skills, give that kind of dedication, perseverance, and focus on this field to, sort of develop ourselves into this endometriosis excision specialist. So it takes some amount of effort, which not everybody tends to, get inclined towards that area. So that's why there is a dearth. There's still a dearth of endometriosis excision surgeons all over the world. I'm talking about. Even on the Western side, you might think it's very developed, but believe me, even in places like UK, USA, there is definitely a skewed ratio between the routine gynacs and the endometriosis excision specialists, and there's definitely a dearth of specialists dealing with surgical management of endometriosis.
Yes, sir. So there is this last question that I want to ask and then end this session on endometriosis. So we have a lot of groups coming up on social media where some random people will talk about endometriosis or, some PCOS, and then they will say some weird kind of things and people will fall for it. So like, does the holistic method actually help out the people who are suffering from endometriosis?
Yeah, so let us understand that this is a chronic disease, okay, just like diabetes and many other conditions, or an inflammatory bowel disease or a Crohn's. It's a chronic condition, okay. Now, in chronic condition, you definitely need a holistic approach. So there are many things like diet regulation, lifestyle modification, exercise, pelvic physiotherapy, okay, pain management by anesthetist also. So these things are there, but they're complementary. Okay. When the quality of life is affected, then only surgery helps primarily. And the other things are complementary. Somebody who has undergone, now last month I had a patient by the doctor herself who came to me for the 5th time. She had undergone 4 surgeries at good centers. So I was trying to demotivate her for surgery. In fact, I told her, please don't keep it as a last option. Don't really think about surgery right now. She said, no, sir, I want to take just one chance with you, one last chance with you, because I'm suffering. I get vasovagal attacks with pain. So we did operate. We cleared off some amount of endometriosis, whatever we could. Patient is okay now, but then I'm not really sure how long the effect might last. Because what happens in this case is there's something known as somatization or centralization of pain. Because of the prolonged exposure to this pain, there are certain pathways or pain tracks which are formed. Okay, so these keep on firing even when you remove the pathology. Even after extensive surgery, the pain track sometimes keeps on firing. So that's why we see the pain factor is still there or comes back quite early after a good surgery also. It does happen in some cases. And that is the reason we should not drag these patients primarily for a long time when they're present with severe pain.
Yes, sir.
Because if it's prolonged, then those pain tracks will be formed and, then it becomes a problem. So this is a proper term known as centralization or somatization of pain. So that's why it's very necessary that when they present with severe pain in the first go, they should be considered as candidates for surgical management. Because if done, as I told you, at the right time, does wonders for the patient.
Yes, sir. Thank you so much, sir. I think this is all we need to know about endometriosis. And
thank you so much.
Yes, sir. Thank you so much, sir, for joining here and throwing such great light on this disease.
It was my absolute pleasure.
Yeah, thank you
so much. It was my
pleasure,
Tanush.
Yeah. Yes, sir. So for adenomyosis, sir, I'll create one more link because I had given the time as 1 hour only. I think 1 hour is okay. Another link. So thank you so much, sir.
You want to do it now only, no problem with you.
Not a problem, sir. We'll
I think adenomyosis might not take so much time because it's not because it's a restricted disease to the uterine cavity. So we'll go ahead. Let's finish it off.
Yes, sir. I'll just create another link.
I'm waiting. You are happy with this? All good?
Yes, sir. Yes, sir. All okay, sir. All good, sir. Thank you, sir.
Okay. Yeah.
Thank you, sir.